This video is only for educational purposes. This is a video of a 70-year-old patient who had CABG'd and developed osteomyelitis of the sternum post-CABG due to her diabetes. She underwent 2 debridements and her sternum was also removed. Once the cultures were negative, we proceeded for coverage with Pectoralis Major Flap. As skin and fat are retracted upwards, the muscle also tends to move upwards. So the best way to dissect is to use your non-dominant hand and press down on the muscle while dissecting with your dominant hand. The major vascular supply of the pec major comes from the medial border of the pec minor, and the vessel can be seen here arising. Right side muscle is then sutured. Here it can be seen being sutured to the rib. First, we raise the flap on the right side, pectoralis major. Since she had surgery before, it's not easy to identify the plane. We start by raising the skin and fat above and feeling for the pec major below. At the edge, it's not easy to identify the pec major, but as we proceed further from the edge, we can identify pec major. As skin and fat are retracted upwards, the muscle also tends to move upwards. So the best way to dissect is to use your non-dominant hand and press down on the muscle while dissecting with your dominant hand. This way we free the entire superior surface of the muscle up to the axilla. As we proceed inferiorly, we come to the junction of the pec major and the rectus abdominis muscle. This is the rectus abdominis muscle. The entire superior surface of the muscle has been freed, as can be seen. The pec major insertion on the humerus is then identified. An incision is given over the insertion of the pec major. Once the skin and fascia have been separated and the muscle is identified, a finger is placed below the lateral free edge of the muscle and finger dissection done to lift the muscle from the lateral side. Once the muscle has been raised, retractors are used to retract the pec major and identify the pec minor below. The pec minor can be seen here. The major vascular supply of the pec major comes from the medial border of the pec minor, and the vessel can be seen here arising just medial to the medial border of the pec minor. Always remember this point: the pectoral branch of the thoracoacromial artery, which supplies the pec major, always arises medial to the medial border of pectoralis minor muscle. Muscle is raised from the lateral free edge to the medial side. Then a hand is placed below the muscle, as can be seen. Muscle is then elevated from the costal cartilages. Raising muscle in this way ensures that all muscle is taken and none is left behind, especially at the medial edge, where due to previous surgery, planes are not clearly identified. After releasing the muscle from the costal cartilages, muscle is incised from the ribs below and from the external oblique aponeurosis and from the edge of the rectus abdominis muscle. Releasing muscle laterally from the aponeurosis and superiorly from the remaining part of the sternum. Insertion of the pec major into the humerus is then isolated, and it is also incised to free the muscle from the insertion. Muscle is then delivered into the axilla. You can see the major pedicle, and protecting the pedicle with the fingers, the sternal and clavicular head of the muscles are separated. The muscle is then delivered through the medial edge onto the area of the sternum for coverage. The muscle can be seen sitting very nicely over the entire sternal area. Since the right-sided muscle has covered the entire area without any issues, the left side muscle is only raised partially, so it can sit on top of the right-sided muscle. Right side muscle is then sutured. Here it can be seen being sutured to the rib and to the rectus abdominis muscle of the opposite side. Then the left sided muscle is just superimposed on top. Skin is then closed, and this is the wound at 2 weeks' time. This is the result after 2 months.